Hey class, this is your lecture on the immune system diseases. This is chapter 32 in our textbook. Alright, so there are three major categories of immune disease. We're going to go over each one. It can be either allergic or immune deficiency, so like you're deficient in antibodies or certain white cell or autoimmune diseases, which can be classified really as like overreactions of the immune system. And then you can also look at them. They can be inherited versus acquired. So in your that's pertinent to your immune deficiencies. So obviously inherited is something it's genetic and they're born with it, and it also shows up really early in life. And then an acquired immune deficiency would be, for example, HIV/AIDS. We're going to look at all of that. And then the inherited with environmental triggers are your autoimmune diseases and your allergies. So um, those tend to have a genetic component, so they tend to run in families, but there are also environmental triggers. So that there are things like, and even I was in nutrient deficiency, so there's things like, for example, vitamin D deficiency puts you more at risk of getting allergies and asthma. But for example, for asthma, living in, for example, an apartment where there's a lot of cockroaches, the cockroach droppings can be a really big trigger for asthma, and so that would be an environmental trigger. Smog and cigarette smoke, those are environmental triggers, could be a trigger for asthma. And so if they're not around that trigger, then they just don't have the asthma or don't ever develop it. But if they have the genetic predisposition and are around the trigger, then they develop the, the asthma, for example, or the allergy. Okay, let's look at a normal immune system. So your normal immune system reaction is usually it's slower and specific and long-lived. Now when you get sick, your first reaction is going to be more like an innate, pre-programmed kind of reaction, and then as your body figures out how to defend against it, then and it takes a little bit. You'll get specific antibodies to the pathogen that's infecting you. And then that stays around for a long time. That is also the basis of how vaccines work, is vaccines induce that slower, specific, and long-lived response to different, usually viral antigens, and then the idea is that should give you protection against those antigens should you come across those various viruses. The normal immune system works with inflammation. So inflammation is actually a normal reaction of your immune system. And in the acute stage or acute inflammation is actually really beneficial because it allows your body to effectively fight what's going on and to limit the damage. Inflammation, like we talked about early on this semester, if it is chronic, it can become a problem. So, short-term acute inflammation is good. It's part of a normal immune system reaction, but it's not supposed to be chronically on. The main function of the immune system, it does include differentiation of self from non-self. So your immune system has made an inventory of what is you, and it's always going around and patrolling and looking. Some of the things that it's looking for, it's looking at your own cells to see if they have gotten infected with viruses. Have they become cancer cells or something like that, right? And all of a sudden they maybe don't look like self anymore. And of course, the other things that would be non-self would be pathogens, viruses, bacteria, fungi, parasites that aren't supposed to be there. Now, here's another thing that's pretty cool and I think kind of mind-boggling for you, is that your immune system is actually in part trained by your normal flora. So the bacteria that are part of your guts actually train your immune system, and your immune system can tell the difference between the friendly bacteria and the pathogenic bacteria, which I think is really cool. So your primary lymphoid organs are your thymus and your bone marrow. They produce lymphocytes. So actually the bone marrow is really truly the site of lymphocyte production. The thymus matures up your lymphocytes. We're going to look at that in just a minute. Your secondary lymphoid organs are a storage area for those lymphocytes that have been produced and matured up. So those would be your lymph nodes, your spleen, your appendix, your tonsils, and your mucosal associated lymphoid tissue, also known as MALT. And so they store lymphocytes and are at areas basically where they're most likely to be needed. And they are connected via the blood and the lymphatic systems. So your lymphatic system drains into your circulatory system, your blood, and of course the fluids and stuff from the blood, as they go through the tissue, then of course enter the lymphatic system. So those are all connected. Okay, so let's look at lymphocytes. So within lymphocytes, you have T cells and B cells. Also sometimes known as T lymphocytes and B lymphocytes. Those terms are interchangeable. So your T cells, a whole line of T cells, originate in the thymus. And they from pre-T cells made in the bone marrow. So you have, like I said, the bone marrow is really kind of the site of production. So they make these precursor T cells, send them to the thymus, and then the thymus really makes the T cells. And within the T cells, you have helper T cells and cytotoxic T cells. And even those, there's all kinds of ways to differentiate them. So for example, you had like T helper 1, T helper 2, T helper 17. And even within the cytotoxic cells, there are subclassifications that match those that are apparent in the T helper cells. And these do cell-mediated immunity. So cell-mediated immunity is when the T cells and cytotoxic T cells are attacking or destroying usually like viral infected cells or cancer infected cells and stuff. So it's a cell-to-cell immunity, and that's why they're cytotoxic, and they're also the defense against the viral infected cells and the cancer cells is for the body to destroy those cells. And so that's why they're cytotoxic, because they destroy the cancer and viral infected cells. All right, your B cells, they originate in the bone marrow, and they become antibody producers. So they have to be activated by your T helper cells to a specific antigen. And then before they're activated, they actually look more like this. And then once they're activated and become little antibody factories, they look more like here, like this has this like fried egg look. This is a plasma cell. And part of that that increases in cytoplasm is because the endoplasmic reticulum grows. And the endoplasmic reticulum is the site of protein production, and the proteins that are produced are your antibodies. And so your B cells produce very specific antibodies to the antigen that was encountered, and they're responsible for what's called humoral immunity, which is immunity in fluids, if you will. So since antibodies are in your body fluids, that's why it's called humoral immunity. All right, your innate versus acquired immunity. So your innate immunity has no memory. It's like pre-programmed. The response is the same each time an antigen is encountered. So for example, your macrophages and monocytes are part of your innate immunity. And so they're patrolling around looking for stuff that doesn't belong. And if they find something that doesn't belong, it always is just going to eat it and destroy it. And some of those, part of the innate immunity, are just barriers. So your skin barrier, your mucous membrane barrier, the complement system, again, your macrophages, and then your natural killer cells, which are a subset of lymphocytes that are just kind of pre-programmed to destroy virus-infected and cancer-infected cells, and they're not specific. They're just anything that has a virus type antigen that is displaying or abnormal cancer-like antigens, then automatically that natural killer cell is going to go and find it and destroy that cell, that body cell that's infected. Okay, and so and there's some sort of like certain IgM production is part also of innate immunity. There are some that, and there are two pathogen-associated molecular patterns. So, yeah, those are usually, and they're usually your first line of defense and your first response. Then your acquired immunity actually possesses memory, which is really, really cool. So the response becomes stronger with each successive encounter with the antigen. It has to see it at least once for it to start making antibodies to it. And this is where, of course, humoral immunity comes in, the production of antibodies by the B cells. They have to be turned on, and production has to be turned on and triggered by interaction with the T helper cell. And then, depending on what is going on in the conversation with the T helper cell, it will either produce IgM, IgG, IgA, IgE, or IgD. And for, again, a review on the specifics of that, there's a section, I believe, in your protein chapter on that. IgD, go backwards. IgD is actually like an antibody on the surface of B cells. IgE is an antibody that's involved in allergic reactions. IgA is an antibody that's present in secretion, so anywhere there's mucus. IgG is usually the most predominant antibody, and that's the ones you make to various pathogens. And then IgM is a pentamer, and it is the first line of response. Usually the first one, the spike, is produced first, and then IgG is produced. And it's usually it can be part of the innate immune system, but it also can be specific to a certain pathogen. And by the way, IgA is a dimer also, so it's two antibodies fixed tail to tail. Your cell-mediated immunity is, of course, T-cell dependent, and again, they destroy viral infected and cancer cells. And it is an part of the acquired immune response. All right, so here this contrasts the two. So you have, right here, you have humoral immunity. So you have extracellular microbes, so they're floating around in fluids and stuff. And the responding lymphocyte is going to be a B lymphocyte, and this is after it's been activated via interactions with the macrophages and T helper cells and stuff like that. And then the activated B lymphocytes turns into a plasma cell, secretes antibodies. The antibodies directly attach to the bacteria and blocks infections and eliminates extracellular microbes because the antibodies flags them for removal. Okay, so in your cell-mediated immunity, for example, so you have those phagocytosed microbe inside a macrophage, interacts with the T helper lymphocytes, and macrophage is activated. It then eliminates these microbes that have been phagocytized. But then what is not portrayed here is that T helper lymphocyte then goes also and activates some B lymphocytes against those microbes in case they're floating around. And then if you have intracellular microbes like viruses that are replicating within an infected cell, some of those antigens are going to show up on the cell membrane, and the cytotoxic T lymphocytes can be activated against them. And once they're activated against those viral antigens, and it sees a cell is infected with those viral antigens, then it's going to attach to that cell like it does here and automatically destroy the body cell that's infected with the virus. Therefore, it does release some of those viruses that were formed, but it stops the formation of any other viral particles there, or virions. Okay. So the basic immune mechanisms is protection against non-self tissues and cells. Once an organism invades the body, it is engulfed by macrophages or dendritic cells, and because they're non-specific, so they look and they see, oh, this does not belong, so it just eats it up, and the macrophage will take it and present it to the T helper cell. So it presents antigens of that organism. And the T helper cells will signal to the B cells, the killer T cells, or the cytotoxic T cells, and your regulatory T cells. So we haven't mentioned the regulatory T cells yet in detail. The regulatory T cells are important to stop the immune response. So we know B cells, like I just said, form plasma cells, and plasma cells make antibodies against that specific invader. And your cytotoxic T cells, or your T killer cells, will destroy any viral infected cells or normal cells and that are associated with the antigen. The importance of the regulatory T cells is that immune system needs to be reined in, and if it is not reined in, what you can get are a lot of the autoimmune diseases. So one of the mechanisms that's at the base of your autoimmune diseases is a, a, a lack in proper function of the T regulatory cells or regulatory T cells. So sometimes they're there, but they're not doing their job, or sometimes there's not enough there. And so it can't turn down that immune response, and that immune response kind of runs away with itself. And so any disruption in this process will lead to immune deficiency. The disruption can determine the type of immune deficiency. So that's anywhere in that whole cascade of stuff. All right, so let's talk hypersensitivity. So hypersensitivity is an immune response that leads to tissue damage. And it can be categorized by the type of antigen or by the mechanism. So if you look at the type of antigen, then hypersensitivity is either an allergy, autoimmunity, or alloimmunity. So allergy, it would be a reaction to something that's normally harmless. Like, for example, pollen would be an example. Like, pollen is not harmful to your body. There's really nothing, it's not a pathogen, it's not threatening. But when you react to it, that's an allergic reaction. Autoimmunity, again, is immune system turn against your own body. And alloimmunity would be your immune system turn against a foreign part that's in your body. So that would be a transplant, usually. If you look at the mechanisms, we can go type 1, type 2, type 3, or type 4. So type 1 is IgE mediated. Type 2 is tissue specific. Type 3 is immune complex mediated. And type 4 is cell mediated. Okay, so hypersensitivity reactions, they have to be sensitized to an antigen prior to a reaction. So the rule is with hypersensitivity reactions, and allergies is one of those, is you will not have a reaction the first time you encounter that allergen or that antigen and stuff like that. So for example, if it's a bee sting, the first time you're stung by a bee, you're not going to be allergic to it. But you could develop an allergic, you could be sensitized to it. And then the second time you're stung, then you can have a big hypersensitivity reaction. So immediate hypersensitivity reactions can occur in minute to hours. They are categorized usually as anaphylaxis, which is well, there's immediate that's kind of benign, and then immediate can turn into anaphylaxis, which is really severe. In an anaphylaxis reaction, systemically, you have itching, erythema, headache, vomiting, cramps, diarrhea, and breathing difficulties. And on the skin or cutaneously, you'll see hives and stuff. So the problem with anaphylaxis is that it can, again, with the breathing difficulty, it can stop your breathing, and this can happen really quickly. Now, not all immediate hypersensitivity reactions are anaphylaxis. Okay, there are some delayed hypersensitivity reactions. They take hours to days. The typical reaction is exposure to poison ivy or poison oak. So usually, what happens is you come into contact with it, and maybe you don't know that you came in contact with a poison ivy or poison oak, and you will not have any breakout until at least 24 hours later, and sometimes even 48 hours. That sensitization, once you're sensitized to an antigen, can be long-lived due to your immunologic memory. So a lot of times, if you're sensitive to something, you are going to be sensitive to it for the rest of your life. There are sometimes some things that kids can outgrow, and they can be sensitive to it when they're little, and then as adults they're no longer, but then sometimes it just stays with you for the rest of your life. The severity of a hypersensitivity reaction depends on the variety of factors. The mode of transmission and the dose of the antigens are two big factors that play into that severity. Mode of transmission will include whether or not the antigen is introduced by respiratory, GI, circulatory, or skin. And then, of course, the dose is self-explanatory, how much of it you have encountered. All right, so the type 1 hypersensitivity, so it's classified by mechanism. So it isn't immediate hypersensitivity, so it happens within minutes to hours. And this one is IgE mediated, and IgE will bind to the mast cell receptors. So again, this is one, so let's just use bee stings again as the example. The first time you are stung and you encounter the venom of the bee, you're not going to be allergic to it. Okay. But your body will see it and decide it doesn't like it. It will process that antigen and then it will start making the IgE and the IgE will be present in the cells. The lymphocytes will be triggered to that. And then what happens is the second time you're stung, that IgE is triggered and there's a bunch of IgE that's produced because the antigen now is present. And all that IgE bound to the antigen, the bee sting antigen, the bee venom, will bind to your mast cells. And the mast cells will then release histamines, proteases, and either other chemotactic factors, and you will have all the allergic reaction symptoms. Antigen contact in type 1 hypersensitivity is usually low dose via mucous membranes in the respiratory or GI tracts, or obviously via the skin for a bee sting and stuff like that. And what happens is, of course, there are preformed IgE antibodies that elicit an immediate response, and the response can occur in seconds or minutes. So again, those IgE antibodies are there from the first encounter. Now, it is possible also to develop an allergy to something you've eaten for quite more than once. Let's say you've eaten something for a long time. Let's say strawberries. You ate strawberries your entire childhood, and then somehow, as an adult, all of a sudden you become allergic to strawberries. So it is possible that at one point in time your body decides it doesn't like it. Okay. It is also possible to outgrow certain allergies. All right, so the effects of the histamines, the protease, and the chemotactic factors that are released by those mast cells are that you get contraction of the bronchial muscles, so that contracts the airway, makes it hard to breathe, and increases your vascular permeability, so that increases inflammation and stuff, and also dilates the blood vessels. Now, where some of this obviously can become dangerous is if the bronchial muscles are too contracted, plus there's a swelling and all that. Breathing can become really difficult. The throat can swell shut. And then if there's a mass dilation of the blood vessels, of all the blood vessels, then what can happen too is the blood pressure can drop dangerously low. So this can all be life-threatening. And by the way, the antidote and what you have to use to save somebody with type 1 hypersensitivity is an EpiPen, so is an injection of epinephrine. And so usually if somebody has one of these life-threatening type of allergies, they usually should have some kind of EpiPen somewhere around on them. So again, the manifestations of these can include circulatory problems, like in bee stings, respiratory, like in asthma. GI would be like food allergies, and skin reactions can be latex allergies. And again, some of them are systemic and can cause anaphylaxis, and some of them are not systemic. Some of them are just annoying. So asthma can be life-threatening. It is possible to die of an asthma attack. The GI ones, it makes you really, really sick if you're allergic to a food. Plus, you get the hives, and it's quite bothersome. All right, so let's talk type 2 hypersensitivity. So this is a cytotoxic hypersensitivity. So it's triggered by the binding of IgG or IgM to tissue-specific antigens on cells or external antigens on tissues. So this is your typical ABO incompatibility reaction or RH incompatibility reaction. There are, however, 5 different mechanisms for type 2 hypersensitivities. So you have activation of the classical complement pathway. So those are your HBO and hemolytic disease of the newborn, which is RH incompatibility. You have phagocytosis by macrophages. So this is seen in autoimmune thrombocytopenic purpura, where the macrophages eat up the platelets. It can be caused by neutrophil damage, as in good pasture syndrome, where there's destruction of the basement membranes and the kidneys and the lungs. We're going to talk about this one in a minute. And the natural killer cells can be activated against parasites and cause these cytotoxic hypersensitivity reactions. And antibody binding to cells can cause a cell to malfunction. So an example would be Graves' disease. So the way that works is on the outside of your thyroid follicular cell, you have the receptor for the thyroid stimulating hormone. And when the thyroid stimulating hormone binds on that receptor, it causes the thyrocyte, the thyroid follicular cell, to produce thyroid hormones and release them. Okay, that's the normal mechanisms. When Graves' disease, an antibody binds to that receptor, and that receptor thinks that TSH is bound to it, and then causes production of thyroid hormones. So what you have in Graves' disease is that there's an excess of thyroid hormones and a great increase in your metabolism, and it's all because an antibody is basically mimicking TSH. Your type 3 hypersensitivity is an immune complex hypersensitivity. So it's an antigen antibody combo that has happened like in liquid form. They've bound, right? And so in plasma or something, and then those antigen antibody complexes get trapped in tissues, and that causes damage. They are not tissue specific. And RA, rheumatoid arthritis, and post-strep glomerulonephritis are a couple of examples of type 3 hypersensitivity, and some of the mechanisms in lupus are also type 3 hypersensitivity. So again, here you can see the immune complexes here, and they deposit on like the endothelial cells or basement membranes and stuff, and then you have complement and Fc receptor mediated recruitment and activation of inflammatory cells, and so there's inflammation and neutrophils that show up, and there's damage to that area. Again, it is not tissue specific, and it tends to be systemic. All right, type 4 hypersensitivity is a delayed hypersensitivity. Again, so this is a typical poison ivy, poison oak type of exposure. It is also the typical reaction to your TB skin test. So it takes 48 to 72 hours for the mechanism to become apparent. It is mediated by T lymphocytes, and your natural killer cells and cytotoxic T lymphocytes directly attack the cells, the body cells that are that been coated with that have the antigen that it's been sensitized to. So contact dermatitis and graft rejection again are the two biggies. So poison ivy, poison oak is an example of contact dermatitis. But if you ever had an allergy to metal, to nickel or something like that, when you have a breakout where there's a belt buckle or a watch or something like that, that is contact dermatitis. And so that is a delayed hypersensitivity reaction. And then a graft reaction in a transplant. So a lot of times those are delayed hypersensitivity reactions. And they are reacting to the allo antigens there, and it takes a little bit, but then it's going to start destroying that graft, that transplant. It can also be associated with autoimmune mechanisms. So RA has some parts of type 4 hypersensitivity in it, Hashimoto's and type 1 diabetes. So in Hashimoto's, you have destructions of the thyrocytes. The antibodies are actually specifically to thyroglobulins and thyroperoxidase, which are intracellular proteins inside the follicular cells. And then type 1 diabetes, it's the beta cells in the pancreas, those that produce insulin. The antibodies, the hypersensitivity to T lymphocytes attack. It's a cell-mediated, so it attack that specific tissue, those specific cells there of the pancreas. And there are overlaps between hypersensitivity and autoimmune disease, as you can see. There is an example in most of these. And your allergies are a type 1 hypersensitivity reaction. So type 2, 3, and 4 hypersensitivity reactions can be related to allergies and then can produce allergic type reactions. In true allergies, you have high levels of IgE produced, and you can actually draw blood and check for various IgEs to, various compounds that are typically allergenic. So you can check it for bee stings. You can check it for, like different foods like strawberries and wheat and different things like that. Symptoms of a type 1 hypersensitivity, again, as we said, range from troublesome to anaphylaxis. We already covered anaphylaxis, which is a life-threatening complication. The lab test or IgE levels, your total IgE levels don't aid in the specific identification of the allergen, but it will show that you're having allergic type reactions. But there are also serum tests that are available for specific allergens, and they can be for IgE or IgG allergens, and you have to know what you want. So sometimes there are certain panels that have, like the food panels or whatever, to have some of them lumped together, but there's usually, the doctor would suspect certain allergens and then would order tests for those. And the symptoms, I meant to say, well, the troublesome symptoms of allergies are your runny nose, sneezing, watery eyes, maybe a little trouble breathing, some headaches and stuff like that. So just think of your seasonal allergies. It's just kind of annoying, but it's just not life-threatening. And will and flare reaction is a way to test also for allergies. So it's a skin test. It has to be done by an allergist, and this is where they will inject different antigens to under your skin, usually on either arms, upper arms, or your back, and they do this pattern with each, like it's like almost like a table, like rows and columns, and they lay it out to a certain pattern, and they'll do various allergens that are common, and then measure the reaction, the redness around the prick. So they poke the skin with the antigen. Okay, so let's get into autoimmune diseases. So in autoimmune diseases, the body loses the ability to differentiate self from non-self. And then self-antigens are seen as foreign, and then that tissue is destroyed. One of the theories behind autoimmune diseases is that of antigenic mimicry. So a hapten, so a really small molecule, binds to a self-antigen, and all of a sudden that looks like a pathogen of some sort, and your body decides to attack it. There will be autoreactive lymphocytes that are present, and normally autoreactive lymphocytes are supposed to be destroyed. They should not be, like, those clones should be destroyed. But if they're allowed to persist, then they would start attacking whatever tissue they've been sensitized to. And then there's a breakdown in immune regulation. So that's where those regulatory T lymphocytes come in. They're supposed to regulate and turn down that immune system. If they're not present, or if there's not enough of them present, then the immune reaction can go unchecked. And so, there's a couple of examples here of mechanisms. So let's get into some specific ones. So we have systemic lupus erythematosus, or lupus, or abbreviated SLE. It is a chronic inflammatory disease. The antibodies are produced with several self-antigens, such as nucleic acids, so that's your DNA and RNA, red cells, your coagulation proteins, and phospholipids. There are a combination between a type 2 and a type 3 hypersensitivity. And the symptoms of lupus are a fever, joint pain, a rash across the bridge of the nose. It's like a butterfly rash. Malaise, fatigue, anemia, and cardiovascular disease. And so this is a systemic disease, and it's progressive. The lab tests for lupus include the ANA test, which is anti-nuclear antibody, and it's still very commonly used to diagnose and monitor lupus. The presence of anti-SM antibodies is considered diagnostic for the disease. If the titers fall, the patient is responding to the treatment, so it's a way to monitor treatments. ANA testing is difficult. It's a difficult test to perform and interpret. Pattern recognition can be made confusing due to the presence of multiple antibodies and a mixed pattern. Also, many of the antibodies produce a speckle pattern and thus cannot be distinguished. There are some ELISA assays available for specific antibodies, such as anti-DNA, anti-SM, anti-SSA, and anti-SSB, and anti-RNP, among others. Rheumatoid arthritis is our next one. It's also chronic systemic and inflammatory autoimmune disease. The antibodies are against the synovial lining. So those are all your joints that allow you free movement. So hands, wrists, knees, hips, all of that. It is progressive and disabling. So you get this crippling here of in the joints and loss of mobility and stuff. The rheumatoid factors are IgG and IgM against the host tissue. The disease mechanism is both genetic and environmental. Your diagnosis lab tests are anti-CCP tests, which is specific for rheumatoid arthritis and is often used to diagnose the disease in its early stages. Your rheumatoid factor is not as specific because it is found in a variety of other conditions, but it is used to monitor the disease. Other monitors include those that measure inflammation, such as the SED rate and the CRP. And your synovial fluid analysis is used to rule out other disease processes like gout and pseudogout, in which you would see crystals. When talking about environmental triggers, for example, one of the things we don't always stop and think about is that as human beings, in the last, let's say, 100 years, we have created more than 80,000 chemicals, and they've not been really thoroughly tested and vetted as to their safety. But even if they are tested, and they're like, okay, this is safe, they're usually tested in isolation and not in synergy with all the other chemicals. And since there are chemicals in so many things and can be so many interactions, if you think of just 80,000 chemicals, the amount of combination of reactions is literally infinite, and so it makes it really, really hard to test. And so some of these chemicals, even just low dose exposure, chronic exposure over a lifetime, could be, for example, an environmental trigger for an autoimmune disease. And so, and these could be things that are in our food, in our cleaning products, in our personal care products. It's quite amazing if you really start digging into that. And so, I mean, that can be one of the biggest sources, I think, of autoimmune diseases. So for RA, for example, you have susceptibility. So, for example, the HLA gene is one of them, plus environmental factors. So here, the chemicals, infections, smoking, and stuff like that. And the environmental factors can modify the enzymes. The susceptibility genes can lead to failure of tolerance and unregulated lymphocyte activations. And then you get B and T cell responses to self-antigens, including the antigens in joint tissues. These are all your autoreactive ones there. And then you have these start destroying your synovial linings and stuff. You have cytokines, you have inflammation, and then you have destruction of the lining and destruction of the cartilage and bone. All right, Sjogren's syndrome is a damage to your exocrine glands. So those are the glands that produce saliva and tears, etc. So you get really dry eyes. Primary by itself is one of the forms that you would just have Sjogren's syndrome, period, nothing else. Or it can be secondary disease, so you have it with lupus or with RA or with scleroderma. Those are some of the examples of like other autoimmune diseases that tend to happen with Sjogren's syndrome. Also, on a side note, if you have one autoimmune disease, you are more likely to get another. So, for example, if you have celiac disease, which is an autoimmune disease, you actually are more prone to develop type 1 diabetes and to develop Hashimoto's thyroiditis. With Sjogren's syndromes, you get lymphocyte infiltrates in the exocrine glands. It starts to be localized, but then it progresses. For your lab test, you do the ANA pattern, and in Sjogren's, it will show a speckle pattern. and that would be indicative of either anti-SSA or anti-SSB antibodies. About 70% of patients are positive for anti-SSA and 50% are positive for anti-SSB. Goodpasture syndrome and then amyloidosis. So Goodpasture is a rare autoimmune disease. It results in bleeding in the kidneys and the lungs because you have a type 2 hypersensitivity with antibodies to collagen type 4, which is in the basement membranes of the kidneys and the lungs, and you have anti-GMB for glomerular basement membrane antibodies. And so it slowly destroys the kidneys and the lungs in those patients. In amyloidosis, this comes from insoluble amyloid fibrils that deposit in tissue or organs, and it is can only be diagnosed by biopsy. All right, let's talk immune deficiencies now. An immune deficiency is a defect of the self-defense portion of the immune system. If it's from a primary cause, it's because of a genetic mutation. And if it's from a secondary cause, it's because of an illness or aging. An illness, for example, would be infection with HIV. Okay, Wiskott-Aldrich syndrome. It is a rare X-linked recessive disorder in which you see thrombocytopenia, immunodeficiency, eczema, and susceptibility for tumors and autoimmune diseases. The CBC results are low white cell, low red cell, and low platelet count, and low levels of IgM and IgA. Next, you have ataxia telangiectasia. It's an autosomal recessive neurodegenerative disorder. The defect prevents repair of DNA, and you get dilation of the capillaries in the eyes, ears, neck, and extremities, which leads to cell death in the cerebellum, cerebrum, in the immune system. None of that is good. And your symptoms are going to be infection, malignancies, and ataxia. So ataxia is what's going on here. Takes skill to trip over flat surfaces. It's just, think of it as clumsiness. So somebody that tries to walk through a door, like normal doorway, but then like bumps their shoulder on the door frame or trips over their feet, or just like, they basically kind of sometimes appear like they're super clumsy, or they're like move around like a drunk person, but they're not, and so this miscoordination, this clumsiness is known as ataxia. And the diagnosis, you will have low immunoglobulin levels, and you will also check the tumor antigens, because since you have malignancies, you can check the tumor antigens, and of course genetic testing also, since it's an inherited disease. Okay, DeGeorge syndrome is also known as congenital thymic aplasia, and it affects T cell maturation. You have a small thymus or no thymus at all in the parathyroid glands or lichen. And you also have structural defects of the heart and you have facial abnormalities in DeGeorge, and the immune system is crippled. So it's crippled because the cell that really coordinates the entire immune system is the T helper cell, and it's not been matured up, so it doesn't know what to do, and so that will cripple the immune system. Then you have Bruton's agammaglobulinemia, also known as X-linked agammaglobulinemia, or XLA. You have the Bruton tyrosine kinase enzyme, which is necessary for B cell precursors to mature, and that is not there. So that results in no plasma cells and no antibodies, and that means really bad immune system. And that means they are susceptible to bacterial infections, because those are extracellular pathogens, and you fight them with antibodies, and antibodies aren't there. This one shows up around 6 months old. You have common variable immunodeficiency disease. It's a collection of B cell and immune globulin disorders. It is the most commonly diagnosed immunodeficiency. It is apparent after 2 years of age, and it can show up anywhere all the way up to 20, so early adulthood. And you will see a hypogammaglobulinemia, so low levels of your gamma globulins, which are your antibodies, IgG is often the one that's low, but it is also possible to see low IgM or low IgA. And they can have a normal number of B cells, they just don't produce antibodies, or they don't produce enough antibodies. So they tend to catch everything that comes around and stuff too. And then you have severe combined immunodeficiency syndrome, also known as SCID. It is a spectrum of disorders, the most severe of which is reticular dysgenesis. And in that one, you have no T cells, no B cells, and no phagocytic cells. So basically, you have no immune system. And of course, then most die in utero or soon after birth because they have no way of defending themselves. Most patients with SCID lack lymphocytes, but have the other white cells, so it have a partially functioning immune system. And then you have your complement deficiencies. Those deficiencies of the classical and alternate pathways are in common. The lectin pathway component deficiencies are the most common. And when you have those complement deficiencies, you see an increase in bacterial infections because part of complement does is destroy bacteria. In a lab test, you can check for C3 and C4. That's pretty easy to do in larger clinical labs. But reference labs can do your CH50, C1, C2, and C1Q analyses. All right, let's look at this case, and then we're going to think through it. So Braden is 8-month-old. He's brought to the ER because he was listless and had a fever and cough. This is his 4th respiratory infection in 4 months. The provider ordered a CBC, BMP, and UA. The results are as follow. So on the CBC, as WBC is 2,000, which it would be a white count of 2.0. The RBC is 4.24, which is good, a little bit low, but good for a little guy. H&H 15.8 and 48.2. Not bad either. MCV is up a little bit with 102. And the platelet are 250,000. Seems adequate to me. The BMP, glucose is 100, BUN is 25, sodium is 142, potassium is 4.5, chloride is 102, and the calcium is 9.4 units as listed. All that seems normal to me. UA is straw yellow with a specific gravity of 1.015, negative glucose, 1+ ketones, and nothing on the microscopic. So out of those, pick out the ones that are abnormal. If you paid attention, you should know that already. What other tests would you order? So for this little guy, because he's having repeated infections, it would be nice to see what his gamma globulins are, right? What are his IgG, IgM, IgA? And diagnosis. So let's think through this one, okay? I'm gonna go back to some of the other ones so that you can see, okay. Is it a complement deficiency? Could be, possibly. Could it be SCID? So it could be maybe one of those SCIDs where it lacks lymphocytes but have other white cells, because then he's prone to having some bacterial infections. So since it can't be common variable immunodeficiency because he's only 8 months old and it's already showing up, and this one doesn't really show up till after 2 years. So probably rule that one out. But now this one shows up around 6 months old. So Bruton's A gamma globulinemia. And so you would have no plasma cells and no antibodies. So I would definitely want to check to see what's going on with his antibodies so you can have a more definite diagnosis. So this one is definitely a top possibility because of the age of presentation and the signs and symptoms. So I think they would have noted if he had facial abnormalities by then with the immune system that's crippled. So I don't think it's DeGeorge. And then this one, it's neurodegenerative. Right now, what he's presenting is not so much neurodegenerative. And it can't be Wiskott Aldrich because even though his white count was a bit low, his red cell and his platelet were adequate. So again, I am thinking that Bruton's gamma globulinemia is more likely, potentially a SCID, one of the forms of SCID. Like I said, there's a whole spectrum of them. And potentially, maybe a complement deficiency. That's possible. Again, so maybe we would order some complement levels too. And our human immunodeficiency virus. So HIV is the human retrovirus. It causes a profound immune deficiency because it attacks the CD4 T cells, which is the T helper cell. And your T helper cell is what coordinates your immune system. It is transmitted through blood and body fluids, so usually sexual transmission or contaminated needles or contaminated blood. And again, so the T helper cells, the CD4 ones, are destroyed, and therefore all phases of the immune system are affected because it's the one cell that coordinates the entire immune system. So at first, at the beginning of an infection with HIV, you have like flu-like symptoms, but then the patient will just kind of go asymptomatic. And you have seroconversion where there are now anti-HIV antibodies present and all that. But then once the virus has destroyed enough of these CD4 cells and the CD4 count drops significantly, then you develop the AIDS, acquired immunodeficiency syndrome. So the lab test for HIV. So the HIV screening can be done on serum or saliva. And we look for HIV antibodies, but so they may not be able to detect it in the early flu-like syndrome because the antibodies haven't had time to rise yet. The fourth generation HIV assays by Abbott Diagnostics combine antibody testing with the P24 antigen testing. And the P24 antigen is the first HIV marker detectable after infection. And so this test is available as an immunoassay test. So that would be your top of the line, your best test to get for screening. The previous CDC algorithm just used HIV Western blot testing as a confirmatory test, but the algorithm was changed in 2015. And so if you do the combined antigen antibody assay, so with the P24 antigen and the anti-HIV antibody, and a viral load, that's enough to confirm a diagnosis. So here are the signs and symptoms of AIDS. So in the central nervous system, you can get meningitis, encephalitis, and AIDS dementia. In the mouth, you have herpes sores or cold sores and thrush, which would be present of yeast. In the lymph nodes, you get lymphadenopathy. In the thymus, you get lymphomas. You can get AIDS nephropathy that affect the kidneys. You can get Kaposi sarcoma, which is a type of skin cancer that's typical of AIDS patients. In the skin, you can get dermatitis, folliculitis, and impetigo. In the large intestine, you can get colitis and proctitis. And in the small intestine, you have nutrient malabsorption. And in the lungs, you can get pneumonia, especially PCP pneumonia. And then you have your monoclonal and polyclonal gammopathies, which are disorders of B cells. And monoclonal is one B cell clone producing excess immune globulins or excess antibodies. Examples of monoclonal gammopathies are multiple myeloma and Waldenstrom macroglobulinemia. Those are both covered in your protein chapter. And your polyclonal gammopathies show elevated levels of all immune globulins, so IgA, IgG, IgM, all of them. So RA and SLE are polyclonal gammopathies. And you would have to do a serum protein serum protein electrophoresis to differentiate a monoclonal gammopathy from a polyclonal one. Again, if you will refer back to your protein chapter, it has more detail on all of that. And that is the end of your lecture. Thank you for your attention.